Hi, my name is Bree Whalen, and today we will be discussing anorexia nervosa. What is anorexia? Anorexia is a persistent restriction of energy intake leading to significantly low body weight. It's either an intense fear of gaining weight or of becoming fat, or a persistent behavior that interferes with weight gain. There's a disturbance in the way one's body weight is shaped or experienced. There's a poor self-evaluation of body weight or persistent lack of recognition of the seriousness of their current low body weight. 35 to 57% of adolescent girls engage in crash dieting, fasting, self-induced vomiting, diet pills, or laxatives. Overweight girls are more likely than normal weight girls to engage in such extreme dieting. Middle school girls who dieted more than once a week were nearly 4 times as likely to become smokers compared to non-dieters. Over 80% of Americans watch television daily. On average, these people watch over 3 hours per day. Teens aged 13 to 18 spend an average of 9 hours a day, and tweens aged 8 to 12 experience 6 hours a day using entertainment media, which impacts weight a great deal in my opinion. The setting I chose is going to be an outpatient, and I'm going to use my first assessment called the Body Shape Questionnaire. It addresses body image, a self-report measure of concerns about body shape and feeling fat. The items were empirically derived by interviewing both patients with eating disorders and other women without eating disorders. It is easy and can be completed within roughly 10 minutes, which I thought was appropriate for adolescent boys and girls to take. The purpose of the activity is to determine the severity of their condition and thoughts, behaviors, and habits with food. The next assessment will be a comprehensive occupational therapy evaluation. This is important because I will interview the client and the caretaker or parent to get an idea of what their home life is like. Next, I would use the Eating Attitudes Test, or the EAT. It was created by David Gardner, and it's a widely used self-report questionnaire, 26-item, standardized self-report to measure symptoms and concerns with eating disorders, specifically anorexia. The EAT has been extremely effective in screening for anorexia nervosa in many populations. It's rated on a 6-point scale and based on how often the individual engages in specific behaviors. The questions may be answered easily, with always, usually, often, sometimes, rarely, and never. The body structures and functions required, which will be in our clinical presentation of the client with anorexia, are your arms and mouth to feed themselves, and mental functions are required, including emotions, thought, and cognition. Also, beliefs and spirituality are involved. The client's motivations to participate in the eating activity. And eating is different amongst many cultures around the world. ADLs needed include self-care, shopping, meal prep and cleanup, budgeting, transportation, and health management. Play and leisure are also included. Social participation, of course, is big in America. Socializing with friends and family. Food is always a requirement or brought in as part of a gesture, a nice gesture. So it takes a great part in how we socialize with others. Sensory motor include exercise level and type. The activity limitations include the ADL tasks which will be affected. Mostly would be meal prep and eating. The person is very preoccupied with food and it is their main occupation. The person restricts eating habits and food intake. The low body weight affects a person's ability to think clearly. Poor attention, concentration, and memory are common side effects of starvation. Starvation increases obsessional thinking. This increases anxiety, which results in weight loss and decreased functioning. A distorted perception of body image also impacts on time, use, and the desire to socialize with others. People with anorexia do not know what activities they enjoy, and sometimes have difficulty having fun. Education and work can be affected because the person may have difficulty completing school tasks or work due to being so preoccupied with food. Play and leisure may be affected because they have limited time to do anything else besides becoming preoccupied with food. Social participation definitely takes a huge role in this, as the person may have difficulty with role performance and participating with others and maintaining relationships. Sensory motor, the person is usually very compulsive and they might exercise too much. The OT area I chose to address is their negative behavior. I want to use an interdisciplinary approach, including nursing, medical, nutritional, mental health, and of course an occupational therapist. OT needs to help create new habits, roles, and routines to negate the poor habits that have been accrued. Through engaging in occupations, OT can discover how a person reacts to food-related IADL and help create change in unhealthy reactions. Through participating in other occupations, clients can discover ways to address the needs being fulfilled by the eating disorder. The goal will be that the client will improve their functioning in social, psychological, and physical domains through the use of meaningful, satisfactory occupations, resulting in an increased EAT and body shape questionnaire score by 10% in 4 weeks. The frame of reference I chose is the psychodynamic frame of reference. It helps occupational therapists find the underlying problems beneath the behavior. A study was completed with 43 occupational therapists treating eating disorders. The psychodynamic frame of reference was most favored in helping to determine the why the eating disorder is occurring in the individual. The first treatment activity will be the therapeutic use of self. The therapist can make a therapeutic relationship with the client. It includes understanding and empathy and caring of the client. The therapist accepts the client as he or she is and tries to make a good rapport with the client, and I feel this is most important. Also, task groups can be incorporated. They're generally used by an occupational therapist, and it helps the person learn more self-satisfying and acceptable behaviors and communication skills in a supportive, social, non-judgmental setting. We will be using the bottoms-up approach because I will be looking at the patient or client as a whole, and we will be using the remedial approach because we will be breaking down the tasks of eating and shopping and the IADL and reteaching and reinstructing how to do this in a healthy way. The next treatment activity will be engaging the client in tasks and activities focusing on the IADL that presents opportunities to discuss underlying thought processes. For example, I could lead a cooking group and observe the client and their actions and behavior with the food, how they're looking at the food, touching the food, to kind of get an idea of the extreme relationship that they might have with the food during the meal prep. This will allow for engagement of questions. Maybe they'll open up a little bit more during this activity, and this can help determine underlying issues as to why they have the eating disorder. Again, I will be using the bottoms-up approach. I'll be looking at the patient as a whole, client, and the remedial approach, because once we can determine the underlying issues, we can reteach some of these skills. Treatment activity 3 will be using real-life experiences to promote new positive feelings and behaviors. Planning and preparing snacks and meals, meal pacing, budgeting for food, grocery shopping together, clothes shopping together for appropriate sizes, leisure and hobby exploration. Socializing with peers during group games can also cause everyone to open up a bit. We can plant and care for plants and vegetables and understand their meaning and how great they are for our bodies. We can work on time management skills if the client is having problems with work or school. We will develop volunteer and employment opportunities. This is for adolescents, so we can focus on volunteer and maybe school-based opportunities, after-school programs, things like that, for him or her to participate in. They can become familiar with their own sensory preferences, and again, we will be using the bottoms-up and remedial approach. How can I prove that the client will be progressing? I feel that data collection can be determined through completion of daily journals to determine if the negative thoughts, feelings, and behaviors have changed. We can change the attitude toward food through interviews, talking about food, appreciating food, and understanding the need for food. We can measure through goal pants or even a goal shirt, which could be a pair of pants that the client can wear comfortably and try on occasionally, maybe once a week in each session, to see how they feel, and we can talk about that rather than weighing on a scale and putting a numeric value on them. We can do cooking interventions incorporating all sensations to change the relationship with food, and complete a food journal with entries describing what the food item does to help their body. Every day they can add in what they had for breakfast, lunch, and dinner and describe the food. I can do reassessments on a regular basis to determine if the surveys have improved. I can do interviews with the parent or caregiver to determine if the habits have changed at home and if they have any feedback that they could give or offer to help the client battle this eating disorder. Thank you very much, and have a wonderful evening.